Several terms have been used in the medical literature to indicate this condition. We can find sensory skin irritation, chemosensory irritability, cosmetic intolerance syndrome, status cosmeticus, subjective irritation, invisible irritation, non-immunologic adverse skin reaction, and self-estimated enhanced skin sensitivity. So if we look at the literature, we can find different definitions. Starting from 2002 with Aideco, we can see sensitive skin can be described as a condition characterized by skin prone to develop more frequently flushing, blushing, stinging, and itching after adverse environmental conditions or application of topical products. Going on, 2002, a lay term used by individuals who consider themselves more intolerant to apply products and environmental factors than the general population. Farage, 2006, exaggerated an unpleasant sensitivity of the skin to frequent or prolonged use of everyday products such as cosmetic or toiletries. Then we have sensitive skin is defined by the onset of erythema and or prickling, burning, or tingling sensation due to various factors which may be physical, chemical, psychological, or hormonal. So here we can see the percentage of overall skin sensitivity across the world. We can see an overall global percentage, more than 75%, and a high percentage in European countries as well as in the USA. Focusing on sensitive skin in Europe, these are the countries where we have the highest percentage, like Germany, Greece, and Italy. The characteristics of sensitive skin are, it involves women's skin aged between 30 and 50 years old, is characterized by stinging, itching, burning, flushing, blushing, and is a subjective condition difficult to visualize clinically. Often it can be associated with cosmetic intolerance, fabric intolerance, and it can be worsened by adverse climatic factors. So we can find different sensitive skin triggers. Here we can see the higher percentage of skin triggers in the USA are weather, fabrics, and stress, while, for example, in China, we find topical products or menstrual cycle. The pathogenesis is unknown, is a subjective condition, is associated with atopy, contact dermatitis, and photoreactions, and it can develop into cuperous and rosacea, experimentally associated with barrier function and transcutaneous penetration problems. We can find different levels of sensitivity. So at the lowest levels, we can find sensitivity per sensitive, altered reactive skin, and going up, intolerant, irritated, eczema, atopy, dermatitis. So atopy is associated but not predictive. The incidence of atopy is increased in sensitive skin compared to controls. Other associated factors can be dry skin and altered reactivity. The association with comorbidities, here we can see, is frequent. It can be associated with acne, rosacea, psoriasis, and seborrheic dermatitis. Today, a majority of the general population describe themselves as having sensitive skin. Although this is often considered more of a problem for women, the number of men claiming this condition is substantial. This is a study conducted on 3,300 women and 500 men. A questionnaire was given, and here we can see the percentage of subjects, male subjects and female subjects, responding yes to these questions, such as, do you regard yourself as having a sensitive skin? Do you regard yourself as having very sensitive skin? We can see very significant percentages, not only among women subjects, but also among men. And this is about cosmetics, the same situation. In this USA study, the ethnic variations were studied, and the results underlined a high percentage of sensitive skin among black peoples in the overall population in the USA. What are the instrumental techniques to study sensitive skin? We have the Tavola meter to value the transepidermal water loss, so skin barrier function, corneometer to evaluate the skin hydration and capacitance, pH meter, chromometer for color parameters, and Doppler flowmetry for superficial skin vascularization, even sebometer for sebum skin levels. So what the experimental data tell us? That we have an increased percutaneous absorption, an altered stratum corneal chemical properties, an increased TEV compared to normal subject, and an increased skin perfusion after nicotinase applications. This is a paper where two populations were identified, stingers and non-stingers, and we have the highest peak response among stingers population of percutaneous absorption. So the baseline biophysical parameters in sensitive skin are no difference in pH level respect normal skin, a modestly increased TEV, a significantly increased chroma A, no difference in chroma L, a significantly decreased capacitance, and a modestly decreased sebum level. We have different skin sites, and what happens to different skin sites? This is a study of 2002 in which different skin phase sites were taken into consideration, and TEV, hydration, blood flow were analyzed. So the results underline that we have different variability on the face, and cheek and paranasal area are the most sensitive sites and are useful for identifying subjects at risk. Sensitive subjects have higher blood flow, TEV, and lower hydration levels. Returning to the pathogenesis, some receptors are involved. We have the TRPV receptors expressed by different cells, such keratinocytes, and involved in heat sensation, burning pain, warm sensation, burning, heat, and warm sensation. We have a very important neuronal mechanism for sensitive skin. Here we can see different stimuli like UV, cold, heat, pollution, detergent, acting on skin barrier and activating an electric stimulation and nervous influx with degranulation of mastocyte and activation of vessel vasodilatation, production of different cytokines. And so we have different causes, external and internal causes acting on epidermis and causing redness, frictions, cutaneous nerve hypersensitivity, stinging, itching, burning, and increase of inflammatory skin reaction. There's a cycle in the barrier dysfunction due to oxidative network and cytokine cascade. The sensitive skin signs can be subjective and objective. We have, as we have said previously. So, which kind of test we can perform for sensitive skin? We have thermal sensorial analysis, stinging test, chloroformethanol, dimethyl sulfoxide, erythema after SLS, nicotinates, behind the knee test. The thermal sensorial analysis is widely used in neurology and measures the reactivity of small unmyelinated C and A delta fibers to warm, cold, and pain. The most famous is the stinging test and is a variable of pain which appears and disappears fast every time the nerve is elicited. Even though the test is quite subjective, it is considered a reliable model to screen subject after affected by skin hypersensitivity. And it is performed by applying hydrosoluble substances to the skin like lactic acid or capsaicin. It is performed at the nasolabial fold, an area rich of neurosensorial fibers, and on the area could be applied a warm and humid cloth for a few minutes before, then a solution of lactic acid at 10% using a cotton swab. In this study, subjects were asked, after the application of lactic acid, were asked to describe their sensation with a point scale. Hyperreactors, as we can see here, had the highest values. Each response is induced by the intradermal or topical application of histamine or histamine-like molecules activating mast cell degranulation and is highly correlated with stinging test and reduced by aspirin. Washing and exaggerated immersion test is induced after the immersion of repeated application of surfactants to the skin is used to rank soaps and detergent irritative potential. The effects are evaluated instrumentally with TEV, corneometry, etc., or visually. The treatment that we can use for sensitive skin, and I have finished, are anti-inflammatory actives, antioxidant, flavonoids, modulation of blood flow and capillary permeability, reconstructing the skin barrier function, moisturizers, and inhibitory peptides. In conclusion, regarding sensitive skin, we can say that there are differences in the epidemiology, ethnic and cultural differences, environmental factors are involved, cosmetics, biochemical changes in skin barrier function, alteration in the neurosensory system, and is associated with atopy, barrier changes probably, hormonal changes are probably involved, and vascular changes. And I thank you.